Good afternoon, everyone. Thank you so much for coming to this plenary session on treatment of low-risk MDS, Part 1. I'm Amy DeZern from the US.
And I'm Saskia Langemeijer from the Raddi University in Nijmegen in the Netherlands.
And it's my great pleasure to introduce our first speaker. Hege Garelius from Sweden is going to speak to us about EPO and Lenalidomide in MDS Non-del 5q.
Thank you. Thank you for inviting me. I have no disclosures. You see the picture of these blood bags that we give our patients. And I consider low-risk MDS as a chronic disease. And it would be fine if we were able to change the trajectory of the disease. Maybe we can, maybe we can't. We can also try to prolong a non-transfusion situation, and we can try to preserve a patient's quality of life. I read one paper from Luspatercept saying that reducing transfusion burden by improving anemia is a major treatment goal, and I sometimes wonder if the authorities understand how smart that is. I agree totally with him, but can we argue like that when they only look at survival? Some years ago, I was invited to Brussels to a meeting arranged by the EU about patient blood management. It was a meeting directed mainly to surgeons and anesthesiologists and some hematologists from Greece and Southern Europe that have many thalassemia patients, but somehow I was there as well, and we as hematologists also have great use of these transfusions, and it is our responsibility, as it says here, that we must monitor an early diagnosis of anemia and try to treat it correctly. And I'm not sure that transfusions is the best way of treating, but often we don't have anything else. Another thing is also that where does the blood come from? I have recently been to Florida for some months, and I saw at the pharmacy there that you could donate blood and get $20 for it. I'm not sure that was so very wise. We know that the need for transfusions impact the quality of life. People have to come to the open ward at the hospitals, outpatient clinics, to receive transfusions where they meet nice nurses, but they have to go from home. Maria Fenaux from Garelius has shown and recently presented her transfusion study, which showed that at an 8-month landmark, erythrocyte transfusion dependency predicted a shorter survival independently of IPSSM. And I will also show that later in my presentation here. So transfusions is not always good, but the problem is also, is it the disease? That's not so bad that we have to change. Erythropoietin is the thing I'm going to talk about, and it has been used in anemia for MDS for more than 30 years. And you all know this predictive model saying that if you have few transfusions and you have a fairly low serum EPO, your chances of responding to ESA is bigger than if you don't have this. If you need more transfusions, and if you have a serum EPO level that is too high, it's not an idea to try to give it. It was first approved by FDA in 1989 for patients with chronic anemia in kidney disease and patients receiving myelosuppressive chemotherapy. I tried to look, but I actually haven't found on the FDA homepage that it is approved in the States for MDS. However, it was approved by EMA for MDS in 2017. That was after 20 years of using it. And there has been a lot of discussions of which level of serum EPO is best, and the answer is the lower the better. But I don't think it is so good if the serum EPO is above 200. But there have been used different cutoffs for that. A French study from 2010 showed that it was important to introduce ESA early after diagnosis. This was 112 patients with lower risk MDS that had not received red blood transfusions with a hemoglobin of less than 10 grams per deciliter and a serum EPO less than 500. And they could see that if ESA was given less than 6 months after diagnosis with a fairly good hemoglobin level and with a serum EPO of less than 100, it was a better chance of responding. Martin Jedersten is working at Karolinska, and he and the Nordic group performed 2 studies with EPO and GCSF in the beginning of this century. The first one was from 2005, where 129 patients from the NMDS group were followed up for 45 months, and that was patients both with high and low risk MDS, and they were given EPO plus GCSF and had a erythroid response rate of 39%, and the median response duration was about 23 months. The best effect was seen in patients with low or no transfusion need, and also the best effect in patients with low risk MDS. One worry was that this could develop acute leukemia, which was not proven. Then they did another study, this time in collaboration with Italy and Pavia, where they studied a cohort that has not been given ESA due to restrictions. And they could see that the patients that had been receiving ESA were doing better, significantly better than the non-ESA population. And also here, primarily in patients who require fewer than 2 units of red blood cells per month. The EU MDS registry started in 2008, and I suppose many of you have included patients in this observational study. It's a prospective longitudinal observational study in 16 countries and Israel, where the patient is checked every 6 months. And from this registry, we took patients from, that was almost 1,700 patients in the period from 2008 to 2014, where we compared patients that had not received any treatment, neither with ESA or transfusions, patients that only had received ESA, patients that only received red blood cell transfusion, and patients that received both. The median duration of ESA treatment was 27 months, and there was a non-significant survival benefit in the ESA treated. Here you can see the green line are the patients that responded on ESA and was untransfused. The blue line is actually 2 lines, both a non-responder and the transfused who did respond. And then those who did not respond and were transfused had the lowest survival. I should say something more, but I can't forget. And then we did a follow-up study, and we did it the same way. This is a so-called propensity study where 2 groups of patients are electronically randomized, you can say, one group which not has been exposed to ESA and another group that has been, and then we registered how many transfusions or not transfusion they have received. And we had two fairly comparable groups and tried to find out how this was. Serum EPO is not a part of this study, and that is because only 40% of the patients had their serum EPO taken before they were included in the study, so that was not a parameter that we could use. Here we see that there is a survival advantage to the ESA-treated group, with a median overall survival of 44.9 months in the ESA group versus 34.8 in the non-ESA group, which is significant. So this is a significant study showing that giving ESA can improve the survival. And as we have shown in earlier studies as well, the non-transfused fare better than the transfused, and the more transfusions, the worse for patients. In both the second and the first studies, we tried to find something about health-related quality of life, and not surprising, we found out that the patients that didn't need any treatment, neither ESA nor transfusions, had the best quality of life, but the ESA group came second. Those who were given transfusions had the lowest quality of life, irrespective of receiving ESA or not. I'm also supposed to speak about lenalidomide in non-del 5q, and personally in Sweden we haven't used lenalidomide in this context. I know that the NCCN guidelines from the States recommend using lenalidomide, but we have not done it unless the patients are del 5q positive. I will give you an example of this patient. This is not him, it's an AI-generated pictures, and I asked the chatbot to make him a bit gray. At least they have given him a gray t-shirt. He is, but it's a real person. Karl-Erik, born 1944, he was diagnosed with MDS with multilinear dysplasia in 2020 and was pancytopenic. He was started on ESA. He lived somewhere else at that moment, but he started ESA as the first-line treatment, but lost effect after 12 months. And the question was, what kind of things can we offer this man? Lenalidomide, as I said, it has not been used in Sweden for non-del 5q MDS, and I'm not sure it is approved either. But of course, we can pretend that he has got a myeloma and give it, but we did not do that. Luspatercept, we were part of the COMMAND study starting in 2017. That is 8 years ago, and it's still not approved in Sweden, which is too bad. He was too old for transplantation, so we ended up with transfusion therapy. And I think this is, to me, this is a story that I've heard before, and I suppose you have heard it as well, that we end up in this situation. His ferritin went up, and we started chelation with desferril and deferiprone. Deferasirox was not an option. He had some kidney failure, so I didn't dare to do that. And we gave him transfusions, and it was relatively often, and he also had some bleeding in his gut, so lot of blood. But we did a new bone marrow in 2024 where we saw an increased amount of blasts, but no change is in MDS. So we tried with ASA, which was not a success. I think he was even more cytopenic after that. And the outcome was, as you can imagine, a sad story. So in the end, he got palliative care. We could not give so many transfusions at home. His chelation treatment was stopped because he was too tired, and he died at home. So this is to illustrate the unmet need. And I wonder if it is the politicians or the authorities that should do something and not only we with this patient. I will refer some studies that has been done with lenalidomide in lower risk non-del 5q patient. One was led by Valeria Santini. It was an international phase 3 randomized placebo-controlled double-blind study who assessed the efficacy and safety of lenalidomide in transfusion-dependent patients with a low-risk MDS non-del 5q ineligible or refractory to ESA. And the patients were randomized to either receive lenalidomide or placebo on a 28-day cycles. And after 8 weeks, transfusion independence was achieved in 26.9% of the patient and 2.4% of the patients in the placebo group, which is significant. And those who were transfusion independent were also much better in the health-related quality of life. The HOVON study has been referred to many times in this meeting, and that has also been a study to evaluate the efficacy of lenalidomide with or without ESA G-CSF in terms of hematologic improvement, defined by the IWG criteria. But at this study, the patient first received lenalidomide, and those who did not respond was given ESA later on. And this was also patients with a high serum EPO and transfusion dependency, and ESA was added according to effect. And here, transfusion independency at week 24 was 67% for the del 5q patients versus 16% for the non-del 5q patients, which was significant, but it could also show that it had effect on the non-del 5q population. The median duration of transfusion independence was 13.7 months for the del 5q population and 9.3 months for the non-del 5q group. But it was no improvement of hematologic improvement when they received ESA, and maybe that was because they were given ESA at a later stage in the process. And it was also noted that a relatively high grade of hematological toxicity was observed. Studies that came from the States in 2021, led by Alan List, was also a phase 3 randomized control study with patients refractory to ESA and lower risk and non-del 5q. And the theory behind this was that lenalidomide could augment the EPO receptor signaling in vitro. And 195 patients were randomly assigned to either len plus EPO alpha or to len alone. And here you can see a major erythroid response of 28.3% in the len EPO group, and less so 11.5% in the group that received only lenalidomide. And this effect was sustained and even better after 16 weeks. So The question is if this is something that we should implement also in our guidelines. So the main message is to give, if we need to give erythrocytes, we must remember that it can be both good and bad, and we must use transfusion wisely. ESA can improve quality of life and survival in patients with lower risk MDS, especially when started early. And lenalidomide can have an effect even with lower risk MDS non-del 5q, especially in combination with ESA starting at the same time. That was it. Thank you. And the brains behind these studies is Eva and Alex Smith, and great thanks to Corinne von Marwijk as well as the administrator of these two studies.
Thank you so much. And if anyone has questions, please come to the microphone. But I think I'll start. I've really enjoyed your recent study in Lancet Hematology from the EU registry and the quality of life data. Do you have any additional data on quality of life in those patients who were iron chelated or any parameters like that to know where the ESA played the role, where the transfusion independence played the role?
No, I can't answer that question. Maybe Reinhard can answer it, but I don't know.
Fair enough.
I have another question, Hege. You wisely say that you should use transfusions wisely in these patients. Would you advocate also keeping in mind the quality of life in these patients, a more restrictive or a more liberal transfusion policy?
The Nordic group did a study some years ago where the ambition was to keep a hemoglobin level at 12, either with the help of Aranesp or with the help of transfusions. And the quality of life was improved in these patients, actually, irrespective of how you got there. So, yeah. But as you know, transfusions work best in the beginning of a disease, and if we are not clever enough with the chelations, they get more tired. So that is also a work to be done, which we don't do well enough.
Very nice presentation. I have a short question. If I understood you correctly, the EPO patients, they did not induce a lower transformation to acute leukemia, but you observed a survival benefit. Mm-hmm. So why did those patients who did not receive ESA die? What was the reason for dying earlier than those who received EPO? And my second question is, your RE patient looks very good, even he was 76 years old. So why didn't you go for allogenic stem cell transplantation?
He had a heart condition. His kidneys were not so good. I would not recommend him for transplantation, but that's how we do it in Sweden. I don't know the reasons for death, but that is something that I can find out in the registry. But I know that most of the patients with lower risk MDS die of these causes, but also, of course, of heart. But I can't say that, what they died of. It would be interesting, though.
Then it's my pleasure to invite the next speaker, Dr. Maria Diez-Campelo from the Hospital of Salamanca in Spain, to tell us more about EPO and Lenalidomide in del 5q MDS patients.
Thank you. Thank you very much for inviting me to review. We are now moving to another context with these drugs, that is MDS with del 5q. Here you can see the outline of my presentation, and I'd like only to start remembering that the majority of the patients diagnosed with MDS with del 5q are going to present it at diagnosis with anemia, and up to 40% of them requiring transfusion. The main problem of these patients also is that the majority of the patients are going to become transfusion dependent or in need of treatment very early after diagnosis, when they are diagnosed in the non-transfusion dependent phase of the disease. These are data of the Spanish and the Düsseldorf cohort with more than 100 patients, and you can see that very early after diagnosis, we are going to develop transfusions. So the main problem of these patients with MDS and del(5q) is not prognosis, is good, is the development of transfusion dependency. Here you can see the current algorithm for treatment of these patients. NCCN guidelines identifies as preferred treatment for lenalidomide for patients with symptomatic anemia. And in a recently review of the European approach, we identify del(5q) and transfusion dependent, also lenalidomide, and probably low doses of len in patients with non-transfusion dependent anemia based on the results of the SINTRA-REV clinical trial. Why don't we use ESAs in this context? The results of this retrospective analysis for the French team identify that these patients are not in benefit of len, because when we analyze data of the cohort, a retrospective cohort of del(5q), and comparing this with a cohort of non-del(5q) patients, they identify that in this scanty number of patients, the rate of responses are lower, and the duration of response also was lower than we observe in patients with non-deletion Q. And interestingly, in this study, the majority of the patients were in the transfusion-dependent phase of the disease and with a high endogenous EPO level. And these two characteristics, as all you know, are predictors of poor response to ESA. So probably in the context of non-transfusion-dependent anemia, and probably in the context of low risk, low endogenous EPO levels, probably patients not candidates to lenalidomide could receive ESAs with probably better outcomes than these presented here. Lenalidomide is the current standard approach in del(5q) based on the effect of the drug in these two mechanisms of action, due to these two mechanisms of action. One is that is a clonal target therapy for del(5q) clone, and it's also improving erythropoiesis and bone marrow function. And when we put lenalidomide in patients with del(5q), we are able to restore the function on several genes that are haploinsufficient in the presence of MDS with del(5q). Lenalidomide is able to restore the expression of these genes and improve erythropoiesis and bone marrow function. And for this reason, this drug reaches these amazing responses in patients with MDS and del(5q that is translated in an improved outcome. The current approach for patients in transfusion dependency is treat the patients with 10 milligrams per day for 21 days, because we reach amazing responses regarding transfusion and dependency very quick after initiating therapy with a very robust responses, median hemoglobin increase of more than 5 grams, and with prolonged duration of response. More interestingly, and due to the fact that it's a target therapy in this context, patients reach, in this context, transfusion dependency, cytogenetic responses in half of the patients in which treat, and the patients responding to this treatment are in a better outcomes as we describe in here in this slide. Here you can see that outcomes for AML and overall survival are better when the patient reaches response according to erythroid response or cytogenetic response. So the reason for treat these patients with len better than ESAs is also to improve overall survival due to this target therapy. Regarding adverse event, it's expected that when we start with lenalidomide and the bone marrow is completely full of del(5q) clones, the target therapy is going to induce several different degrees of hematological impairment, and these are translated in this adverse event. Neutropenia and thrombocytopenia is frequent during the first cycles, and after these first cycles, and when we restore normal hematopoiesis, the patient decrease the rates of hematological toxicity. This is a very nice figure of the effects of lenalidomide in the cellular component and translated in these clinical effects. The other adverse events related to LEN are generally in low frequent and generally moderate to mild. We also address that several patients have to discontinue for treatment after therapy, and we recently analyzed with the Italian team a cohort of more than 100 patients that discontinued lenalidomide after therapy. And we identified in this interesting paper that even that the majority of the patients that discontinued for lenalidomide, they are still on benefit of the treatment during a very long period of time. Only 40% of the patients, sorry, because this is completely impossible for me. Only 40% of the patients develop transfusion, lose the transfusion independency. And for the majority of the patients that lose this transfusion independency, the median duration of this benefit after discontinuation was very prolonged, more than near 5 years. Even that the majority of these patients lose these cytogenetic responses. Interestingly also, when we retreat the patients with LEN, we reach again amazing rates of response. Up to 60% of the patients reach again transfusion independency. And it's very important because we identify the factors that patients have and are translated in a prolonged duration of response after discontinuation. And it's interesting, one of these, and it's related to the SINTRA-REV clinical trial, because in these patients with the lower rates of transfusion dependency, these are the patients that are going to have a better duration of the transfusion independency after discontinuation. And it's similar to our approach in the SINTRA-REV clinical trial. We start early lenalidomide in non-transfusion dependent anemia, and with a limited period of time of duration of the treatment with lenalidomide. Finally, I'd like to highlight that TP53 mutation, as we have seen several times during this meeting, is present very frequently in patients with del(5q. It's an early event occurring in between 50 to 20% of the patients, and is associated with a poor response rate regarding erythroid responses and, of course, cytogenetic responses. The main interesting thing with these TP53 mutations is that these patients are in an increased risk of AML. And according to the recently published paper of the most important series in this context, published by Julia Montoro of the Spanish team in a collaborative international effort, we identified that TP53 should be characterized mutation in this gene according to these three situations: wild type, multi-hit mutant form, or monoallelic form according to the BAL allele frequency. And patients in a high risk of overall of decreased overall survival and increased risk of AML evolution are those with the BAL allele frequency greater than 20%. And this, of course, with multi-hit TP53. Let's move to another scenario, the non-transfusion dependent anemia. And in this scenario, we, several years ago, identified that lenalidomide could play a role in order to avoid and prevent the patient for transfusions. And for this purpose, we designed the SINTRA-REV clinical trial that is a phase 3 double-blind placebo-controlled multicenter study in patients with MDS, low-risk del(5q, and anemia but no transfusion requirements. The patients were randomized to receive low doses of LEN, only 5 milligrams per day, as compared to placebo, only for 2 years of treatment, and after that, all patients discontinued the treatment and started a follow-up phase of 2 more years. We have a very prolonged period of recruitment and that have extended for a prolonged period of time, and we have, for this reason, very an extended follow-up for several patients. We evaluate in these patients the disease, we perform disease assessment at week 12 and every 6 months during this treatment phase, follow-up phase, and during the long-term follow-up in several patients. And interestingly, we have the opportunity to perform next-generation sequencing every 6 months during disease treatment and evolution. Here you can see the main characteristics of the patients, 61 patients including 40 in the lenalidomide arm, that are typical characteristics of these patients' population, anemic symptomatic anemia in these patients, and with a median time to treatment from diagnosis below 4 months. And regarding the results, we identify that low doses of len, only 5 milligrams per day, are able to delay and decrease the transfusion dependency in patients receiving lenalidomide, as compared to patients receiving placebo, in which after a median of 11.6 months, they develop transfusions. So len is able to decrease the rate of transfusions in the risk of transfusions in 70%. We also confirm that we have better responses than when we use the drug in a more advanced phase of the disease and with higher doses. And with these low doses, the majority of the patients reach very early erythroid responses, and more interestingly, the quality of these responses are more interesting due to the fact that the majority of the patients reach very early cytogenetic responses, and up to 94% of them reach cytogenetic responses. Remember that only 50% of them in the phase 3 trial with lenalidomide at higher doses in the transfusion-dependent phase of the disease. Regarding adverse events, we confirm that we have some adverse events related with hematological toxicity, as expected, some degree of neutropenia and thrombocytopenia, but generally not translated in clinical consequences. Febrile neutropenia or bleeding was not frequent, as well as non-hematological toxicity is not very frequent and generally very well controlled due to the severity. And finally, here you can see the overall survival of this cohort is a 10 towards to a better overall survival, but this study is not powered to identify differences in overall survival, and we have this data regarding AML evolution, not an increase in AML evolution, even in patients with TP53 mutations. Interestingly, we have the opportunity to check NGS in every bone marrow every 6 months during the treatment phase and after that. And here you can see the pattern of the mutations that this patient presented. They are presented with a median of 1 mutation, and the most frequent mutation is, as expected, SF3B1 mutation. Also, TP53 is present, and DMNT3A. We can confirm that when we treat with this target therapy, we are going to address and observe a decrease in different frequencies of different genes that are present in the patient very early at week 12, and of course at the end of treatment as compared to the placebo team. And when we analyze this data, we can confirm that the median allele frequency is reduced very early after treatment and is keeping low at the end of treatment as compared to the placebo patient, in which remain stable and increase at the end of treatment. Finally, we'd like to address the role of different mutations in responses and, of course, prognosis. We have several patients with SF3B1 mutations, and even that these patients are related to response poor in the context of transfusion dependency, we identify in our cohort that early treatment is able to reach responses in the majority of the patients, but the duration of response is shorter. And the patients develop transfusion dependency before 2 years of treatment. AML evolution was occurred also in these SF3B1 mutations in a lower rate than in the placebo arm. And regarding TP53, we confirm that these patients are presenting with lower rates of response, erythroid and cytogenetic, and the majority of the patients are going to lose response very early after treatment, after 1 year of treatment. But this is also prolonged if we compare with the placebo arm. AML evolution is close similar to the placebo arm, and we did not reach the median time to AML evolution. And this is my 2 last slides, remembering my personal approach for these patients. Remember to treat early as soon as the patient develops symptoms. In the non-transfusion setting, the preferred treatment should be low doses of LEN for a limited period of time. And we recommended NGS as mandatory as baseline and during disease evolution, during follow-up, in order to identify this mutation that could be translated into lower responses and risk of AML. ES8 could be a possibility, especially in non-LEN candidates, especially if the patient is in a very prognostic factors of response, but probably shorter duration of response. When the patient is in transfusion dependency, the dose should be increased, LEN10, and is of course mandatory to perform TP53 and SF3B1 mutation. Remember that sometimes patients again should discontinue due to intolerance, or probably in a selected population we can discontinue it with maintaining the benefit in this after treatment discontinuation. And we have an urgent medical need that are those patients in no response on after LEN failure, because clinical trials are now excluding this category. There is one approach now in Italy with Luspatercept, but there is no clinical trial involved including these patients. Finally, I'd like to say thanks to my collaborators in this trial, especially Dr. Pierre Fenaux for be a believer of this trial, and Dr. Cañizo, and of course families and friends. And this is our team of GSMD and our team in Salamanca. Thank you very much.
Now, while I wait for people to walk to the microphone for questions, just a short reminder that you can also enter your questions in the app, and we'll see them on the screen here. But someone reached the microphone, so please go ahead.
Great talk, beautiful talk. Thanks, Maria. Were you surprised not to see an improvement in leukemia-free survival given the very potent anticlonal activity? And if you excluded those with SF3 beta 1 and TP53, did you see an improvement in leukemia-free survival? That's one question. And the second one is, would you think that continuing the lenalidomide even intermittently going forward after 2 years might be a benefit?
That's a very good question. And regarding the AML evolution, we only have 11 patients in the trial developing AML, so the rate is very low, and is lower in lenalidomide patients. We identify lower rates of AML in patients reaching cytogenetic responses, but the numbers are too low, and we did not reach statistical significance. And regarding the continuation of treatment, I think probably it's not necessary in patients reaching cytogenetic response, because the goal of this treatment should be not to increase toxicities. Anyway, you are taking a drug, you are in a higher risk to develop adverse event. And we have several patients, at least 15, that in which we discontinued after these 2 years, and no one of them had developed the transfusion dependency over time, and with a median follow-up of 5 years. So probably it's not necessary, and we don't know, probably we should make another trial addressing this question.
Did you observe also a higher risk of secondary malignancies as have been reported in multiple myeloma?
No, we identify some patients developing secondary neoplasms in both arms, but it's in a low rate in both arms, in placebo and in lenalidomide arm. And the relation between lenalidomide and this secondary neoplasms is difficult to be associated, probably.
There's another digital question from the audience, which is, would you go for early transplant in del5q elderly fit patients seeing the possibility of loss of response within several years.
Sorry, in?
So in the elderly patient
Yeah.
with del(5q, as lenalidomide may in the end, the patient would have loss of response, would you go for early transplant in these patients?
Well, I think that when the patient fail or not respond to LEN, you have to reevaluate very well the disease, because sometimes it's in a higher risk of the disease. But if the patient is in the lower risk setting, probably not move to transplant, because it's a very aggressive therapy, and we should try another approach before transplant. Yeah.
And then another question. You now treat the patients with lenalidomide with the early treatment for 2 years. Could that also be a shorter period than those 2 years? Because I think you saw a cytogenetic response after 12 weeks, and that was stable
Yes.
at the end of treatment.
The majority of the patients reached cytogenetic responses at week 12, and the treatment was maintained during near 1.5 years more. And it's one of the markers that we observe, that is the continued treatment after cytogenetic response for at least 12 cycles is one of the markers of a prolonged response after that. So probably it's not necessary to keep the patient on treatment. It's probably more safe to stop and wait and see. Because if the patient relapse, probably, or become transfusion dependent, probably you can retreat with LEN.
And I think there's one other question. Would you consider Luspatercept treatment in a patient with 5q and an SF3B1 mutation?
Yes, it could be a very good option, because this patient could have responses. With LEN, they respond, but they lose responses very early. But I think that these patients with this mutation, SF3B1 mutation, are in an increased risk of AML. So probably you can take care and follow very frequently because of the risk of AML.
Okay, I think that was the last question. Thank you very much for your wonderful talk. And then we'll move to the next speaker.
It's my pleasure to introduce Professor Pierre Fenaux from France to talk to us about Luspatercept and TGF-beta pathway inhibition.
Good afternoon. I'd like to thank in particular Arjan and Saskia for that kind invitation, especially as I'm probably one of the few delegates who attended all MDS Foundation meetings since Innsbruck in 1988 or 87, I can't remember. So these are my conflicts of interest. Thank you especially for inviting us in this very nice place. This is the River Meuse, and interestingly, there is, if you go eastward, there is a bicycle lane that if you cycle during as far as 374 kilometers will drive you directly to the French Ardennes where my village is, but it's a long way, and I must say I came by high-speed train. So first, I'd like to just remind, which is obvious, but it's probably the basics. There are two ways of treating anemia in lower-risk MDS. One is to transfuse patients, and one is to try to improve hemoglobin level, avoid transfusions. That's why we try to do. And when you transfuse, you see that you spend at least half of the time below 8 grams of hemoglobin. And there is a slide which is probably the most important in my talk, which is the sigmoid curve relating very well the hemoglobin level and the quality of life. So if you're at 10, 11, or 12, you're much better than 8 or even below 8. And this is really crucial for our patients. And there are also other reasons to try to maintain the hemoglobin level. Not the fact that, well, we know that red blood cell transfusions are associated to poorer survival, but it's mainly due to specific disease characteristics. But at least by improving the hemoglobin level, you also reduce the cardiovascular complication of anemia, falls, iron overload, of course. We also have to bear in mind that although our recommendations are generally to transfuse patients at a threshold of 8 grams or even higher, for various reasons, some people tell us it should be 7 grams, but they apply rules for surgery in patients aged 30 to our elderly MDS patients with coronary artery disease, and also practically because when you have 8 grams on a Thursday, you may only be transfused the next Monday or Tuesday. So this is another issue. And of course, transfusions also induce patient dependence on hospital and medical teams. And the cost also is not negligible, and it's at least 15,000 euros per country per year in my country, and sometimes more for patients who are heavily transfused. So, well, we know the contenders and the competitors to TGF-beta inhibitors. Just to remind everyone, of course, ATG gives close to 50% response rates, but in highly selected patients, and also that transplants, when it's performed in elderly patients above the age of 65, still has a TRM often about 15%. This has to be taken into account. So, and also what is important to note is that we're dealing with anemia of low risk MDS, but we know that by analyzing mutations, that is the IPSSM, quite a few of them will be reclassified into somewhat higher risk MDS with perhaps a poorer prognosis, in whom drugs that influence the disease course may be important. Okay, so now TGF-beta inhibition. We know that the TGF-beta pathway inhibits erythropoiesis with different ligands on activin receptors, and the idea is to try to inhibit them, and in particular with a drug like Luspatercept that is able to combine with the ligands of the superfamily, and it particularly targets the activin receptor 2B, which may be important because other drugs, and we'll see, may also have a wider type of action, and including cardiovascular effects like, for example, sotatercept, which, as you may know, improves primary pulmonary hypertension. So it may be important. Anyway, the effect of Luspatercept was first shown in a German trial, the PACE trial, which I'll briefly present later, but largely in a randomized study in MDS with ringed cereblast, randomizing Luspatercept. We all know that trial, Luspatercept at increasing doses versus placebo in transfusion-dependent, red blood cell transfusion-dependent MDS with ringed cereblast. We know the results, 47% transfusion independence, which was the major primary endpoint of at least 8 weeks. Interestingly, as we all know, the placebo arm gave a 15% response rate, which suggests, as we discussed yesterday about the pitfalls about clinical trials, the necessity of having new, which we now have, new response criteria in order to avoid false responses. And we also know that in addition to the baseline EPO level, the major prognostic factor of response was transfusion requirement. So patients with a very high transfusion requirement with Luspatercept didn't have a very good response rate of 21%, but those were patients who had no previous options and so were often waited a lot to be included in the trial. So in real life, the idea is, of course, would be to treat patients before they have such a transfusion requirement. And the median response duration was about 80 weeks with Luspatercept. Now, the side effects did exist with Luspatercept. Well, we know there are very few, there was the placebo. Luspatercept, about 20% of the patients experienced fatigue, which some patients described as different from the fatigue due to anemia. And I think the pathophysiology of this fatigue is unclear and is being investigated. And also dizziness occurs in some patients, which means that some patients have to stop. It is true that it tends to decrease with follow-up, as you can see from the curves here. But it's also because some patients have discontinued. But it does indeed diminish with follow-up, but some patients stop. Okay. And we know also that the drug works in patients with MDS MPN with ring sideroblasts and thrombocytosis. And we also know that the drug is capable to increase moderately the neutrophils in about 80% of the cases, and also moderate increase in platelets by at least 30,000 in 70% of the patients, which probably shows that there is a multilineage effect. Now, the paper has been published. There have been sub-studies published, which are summarized here, and saying that majority of patients escalates to 1.75 milligrams per kilo. So some trials are currently using this drug upfront, this dose upfront. We know that in responders, the mean cumulative duration of transfusion about 80 weeks. There is no obvious clonal reduction effect, that is reduction of the SF3B1 mutated clone. There's a survival advantage in responders, but this is seen with all drugs in all diseases, I would say. And importantly, there are no long-term side effects, especially on progression. And in particular, patients who progressed had almost all unfavorable mutations in addition to SF3B1. And by the way, it's really a subtype where monitoring of NGS is really crucial in those patients. If they remain SF3B1 alone, they possibly never progress to AML, whereas, of course, if they acquire RUNX1, A6L1, etc., they may progress. Now, quality of life has also been analyzed in this trial, and as usual, the results are not obvious. But the reason is, and we're going back to our discussion yesterday about trial pitfalls. What we are analyzing here for quality of life is the treated group and the placebo group, whereas what we should compare is the patients who respond in the treated group, in whom hemoglobin is maintained, as compared to those who are transfused, because this is real life. It is only 50% of the patients respond, so you dilute the effect on quality of life. But if you analyze the responders and the transfused patients, you definitely have an improvement in quality of life, which, by the way, you've always seen when you improve the hemoglobin level. Okay. Now, there are real-life experiences with Luspatercept in MDS with ring sideroblasts published. I'm showing some of the big ones. I'm sorry if I forgot some, but in particular by the FISM, the GFMs, it's the second, sorry, and the recent one in the British Journal of Hematology with response rates of about around 40%, depending on the when patients were treated, the median transfusion requirement, etc. Okay. Now, the idea rapidly came in patients who did not respond to Luspa or who relapsed to add ESAs, because we know ESAs add early in erythropoiesis, and the TGF-beta pathways is later. And those are series published or presented. In particular, Dr. Comon will present at this meeting the GFM series. And once again, response rates vary. But for example, in the French series, the idea is that because you have already two drugs that for which patients are resistant, if you combine them, you don't expect to have an extraordinary response rate. So it may be, yeah, okay. But so now this was for patients with ring sideroblasts, but as I said, the first study was the German PACE study, which used Luspatercept in sideroblastic and non-sideroblastic anemia. Many patients had not received ESAs before, and as you can see, the response rate is better in patients with ring sideroblasts. Sorry, oops. Yeah. 50%, that's the transfusion independence as compared to 34%, and erythroid response is also lower, but still there are definitely some responses in non-sideroblastic anemia patients. And so for this reason, the idea, of Lionel Hades on behalf of the GFM was to try to compare this luspatercept alone and luspatercept plus EPO in those patients. We wanted to take advantage of a previous trial we had published where lenalidomide plus EPO was better than lenalidomide alone in patients with who are resistant to EPO. So these are so it's non-sideroblastic anemia, of course. The trial is ongoing, but the phase 1 escalating dose was presented at ASH with a 30% response rate. What is important, and perhaps Lionel Hades may want to comment if there are questions, is that we see that when you now take a population of non-sideroblastic lower-risk MDS, classified because the inclusion criteria remain the revised IPSS, including for our health agencies, you realize that quite a few of those patients have several mutations and we would be reclassified with the IPSSM as higher risk, and explaining potentially why response rates are perhaps not what we would expect. Okay, there is a second drug now, which is Luspatercept, which is a drug that targets not only the activin B, but also the activin A receptor. As I said, perhaps with more actions, including cardiovascular. We don't know, but the drug has been first published the phase 1 study showing an increase in hemoglobin, also in quite a few patients in platelets with a good tolerance, although fatigue and dizziness appear, like for luspatercept, to exist. And those are the results of a phase 2 trial presented by Dr. Diez-Campelo at Hege, and in 87 patients who, as you can see, generally had high transfusion burden. A majority of patients were ring sideroblasts positive, 69%, and not all of them, only a quarter of them had received ESA. So it's difficult to compare with the medalist results, of course, where all patients had received ESAs. And just the results are certainly promising, as you can see. 55% response, including 50% in this series in patients with high transfusion burden. And results were, once again, patients with low EPO level had better results. So this is certainly promising. We of course, don't need more follow-up, but that certainly is extremely interesting. And this is the response duration with, of course, still relatively limited follow-up, but we have response durations that appear to be at least similar to those observed with luspatercept. Okay. Now, that was the second line, and as you know, luspatercept is approved for the treatment of MDS-RS after ESA failure. What about the treatment of the first-line treatment of lower-risk MDS? And results are largely based on the Commons trial, which was again presented and published, and comparing luspatercept with increasing doses, the classical increasing doses, and EPO alpha. It's always the EPO alpha that's used as a reference because it's the only one officially approved. And the primary endpoint was red blood cell transfusion at least 12 weeks with concurrent increase in hemoglobin by at least 1.5 grams. Those were transfusion-dependent patients, I forgot to say. And clearly the overall response rate for luspatercept is better than that seen with EPO alpha. EPO alpha provides higher response rates when you take into account non-transfusion dependent patients, but when you take transfusion-dependent patients, that's what you expect. And this is true irrespective of the EPO level of the transfusion burden, although once again the transfusion burden effect is seen with both drugs. And it is very positive in patients who are ring sideroblast positive, but no obvious difference in the patients who are RS negative. And we see it with the analysis, only about 1/3 of the patients were RS negative. And so this is now the secondary endpoints, which were transfusion of at least 8 weeks, 24 weeks. And once again, we clearly have an advantage for Luspatercept over EPO alpha. I think there's really no question. For the duration also, overall, 77 weeks for EPO and 120 weeks for Luspatercept, once again a superiority. But when it comes to RS plus and RS negative, you can see a superiority for RS plus, and we showed previously that EPO gives short responses in RS positive patients, and for RS negative patients it's difficult to conclude because of the low patient number. Now, those are now more long-term analysis, and as you can see, in particular, if you analyze at 1 year and 1.5 years, 1.5 years, there's still an important difference, which is perhaps even more important after regarding red blood cell transfusion independence greater than 1.5 years. And we also, especially for long-term response, serum EPO remains a prognostic factor. And when it comes now to the patients, and it's a clear difference for RS plus, and for RS negative patients, we have very few patient numbers. It's true, only 16% long responders with EPO, 24% with Luspatercept, but the patient numbers are small, so it's difficult to conclude. So now the drug Luspatercept is being compared with EPO alpha in non-transfusion dependent patients through the MS study, which is currently including patients. So in conclusion, Luspatercept appears as a reference treatment first line and beyond in MDS RS. I think the difference here appears to be very clear. Red blood cell transfusion requirement and serum EPO level are main prognostic factors of response. There are short-term side effects in some patients, as I said, fatigue and dizziness. There's no obvious clonal reduction effect of Luspatercept. And the question for the difference between Luspatercept and the ESAs in non-ring sideroblast patients, I think the jury is still out, especially because we have few patients so far for comparison, and elritercept is also certainly a promising drug, which is being now going to be tested in a phase 3 randomized study that has just started. So I'd like to acknowledge the Department of Hematology I'm part of in Paris, and finally the French MDS group, which is mainly a group activating trials in cooperation with our colleagues from Germany, Italy, Spain, the Netherlands, through a consortium we call EMSCO, and we are really ready to activate academic trials with others. Thank you very much.
Motion.
Thank you, Pierre. I don't have any question. It was very clear, as usual. But I would like to take the opportunity to comment actually on all three presentations, because it has been, and you as well as Maria, as well as Hege, were talking about treating the non-transfusion patients. And I would like something that has been going on here in this meeting as well as others, why we as physicians are putting up with any hemoglobin or hemoglobin which is 8 or 9. Why, for example, we treat hypothyroidism, and we want the TSH to be normalized, and we want calcium to be normalized, and we are treating iron deficiency. We are looking at the iron, and we wanted the iron or the ferritin to be normalized. But MDS patient with hemoglobin 11 who has poor quality of life, we say, okay, no need for treatment, no need for transfusion, anything. And when the hemoglobin goes down to 10 and 9 and 8, still you have to apologize if you want to give him transfusion. So my question to you, and basically my call to our society and community, I think we should discuss what hemoglobin we need. Obviously, not the number. Mikhail will say that the number is not important. He is right. The importance is the quality of life of the patients. And maybe we should be more critical, and maybe we should be more aggressive with the authorities, whether it is the blood transfusions, whether it is one of these agents, but not to put up with such low hemoglobin with poor quality of life. What do you think?
No, I agree, but it's difficult to obtain, at least in my country, having patients transfused above 8 grams of hemoglobin unless they really have severe cardiovascular disease. And I know in Nordic countries, and Eva may want to comment, they often obtain having patients transfused above 10 grams, but it's difficult to obtain in many situations. And I remember working in a hospital where they said the threshold is 7 grams and everyone had signed. It certainly was 7 grams for surgery in a patient aged 30, but that was signed by all physicians, so I had to abide by, you know.
Thank you. It was a really nice talk. So I'm going to ask you a provocative question, and you kind of answer it, but I'm going to challenge you. So you said that this kind of improvement in survival that we're starting to see in some of these trials is just because they are responding or something like this. But my question is, are we missing something here? Because, you know, we have the data from Diez-Campelo with these early patients doing extremely well and stabilizing. And in some of the studies, and I'm not saying this is directly related to Luspatercept, it could be from an ESA, these patients are randomized to transfusions. So, you know, they probably have an acceptable threshold of hemoglobin. So it cannot be that it's just the fact that they are responding. So the question is it possible that we're missing something biological that maybe is actually outside the bone marrow environment that these drugs are doing, that is maybe promoting longer survival? I think this is an important question because in lower risk, we're always talking about quality of life and these kind of things. And maybe we're starting to see some ideas that we could actually make these people live longer. Just a question.
I don't know.
I think the answer has been really presented in meetings. So for instance, there is some data that some of these are anti-inflammatory compounds. They may remodel like cytokines that are related to cardiac function. I'm wondering actually if it's possible that these agents are doing something else, and this somehow results in longer survival. And maybe we should think about this.
No, at least what is important is to maintain hemoglobin above a certain level, and this is probably associated with improved survival.
Thank you, it was great.
We have a
Then we will continue with the selected abstracts, and the first abstract will be presented by Carlos Ruiz Arenas from Spain, and he will talk about data-driven clustering of low blast patients with myelodysplastic syndromes, reveals biological features driving differences in prognosis prediction.
Okay, so good afternoon. Okay, well, have no conflict of interest to disclosure. And these are the funders. So basically, when we are going to treat our MDS patients, we have two different ways of tackle the problem. On one hand, we have the definition of the risk of if this patient is going to progress to AML. And based on this, we can decide whether to treat or not, or whether we are going to more invasive treatments or others. On the other hand, and as it's been discussed even in this session, depending on the biological entity of our patient, we can go to one treatment or the other. And for classifying patients into biological entities, we have some classifications like this harmonized MDS classification that's been presented this morning too, Well, the patients are divided in 6 subgroups. 3 of them are based on genetic or karyotypic aberrations, while the other 3 are based on the proportion of blasts. However, if we apply this classification to the IPSSM cohort, we can observe that the low blast group accounts for almost half of the patients. So here we hypothesize that there might be additional subtypes that we might be missing that are not currently here. So our goal was to define additional subgroups of low blast using a data-driven approach that will be based on clinical and molecular data. And the goal is that these subgroups somehow will represent some biological entities that currently are not represented in the harmonized classification. So to fulfill our aim, we propose that our subgroups should have these following features. So on one hand, they should present different clinical and mutational patterns. Then they should have difference in prognosis, and then they should have different risk factors that affect the risk. So we did this analysis using the data from the IPSSM cohort, selected all individuals classified as low blast, and we took all the patients that had complete clinical, karyotype, and molecular data. And here you have the descriptives of our dataset. To define our subgroups, we ran a principal component analysis that included 7 clinical variables. And we only included 6 karyotypic events and 9 mutations. We included these karyotypic events and mutations because they were frequent in our population of low blast. And then we defined the groups using a Cummings approach and selected the number of clusters based on a statistical score. So this is our results. We defined 8 subgroups. So the first 2 subgroups, this highly leukopenic and myeloleukopenic, are not defined by any mutation or any cytogenic aberration, but they account for almost half of the patients. Then we have 2 subgroups that are defined by TET2 mutations that account for almost a quarter of the patients. And then we have the other that are defined by karyotypic aberrations that are much less frequent. So here in this figure, you have each number represents the proportions of individuals in the group that is represented in the right that have the karyotypic aberration depicted below. As you can see, the 4 groups that are defined by karyotypic aberrations, all of them have the karyotypic aberration that define the group, and these karyotypic aberrations are relatively rare in the other 4 subgroups. If we go to the mutations, we see the same pattern. So we have that the TET2B allelic subgroup is defined by individuals that have 2 mutations to TET2B allelic, while the TET2 monoallelic also defines the TET2 monoallelic group, but there are also some patients having this mutation in the trisomy 8 patients. So based on this data, we define a classification algorithm to easily classify any of the individuals in any of the low blast individuals in these 8 subgroups. So this is a hierarchical algorithm where we start with the status of the TET2B allelic, and we go checking different factors until we arrive to the monosomy of 7 and trisomy of 8. So again, I want to highlight that this group here, that is the highly leukopenic, that it was the most frequent group, is defined because they don't have any of the things that we use to define the other groups. So next, we wanted to explore if our subgroups had differences in clinical features and mutational patterns in addition to the things that we use to define the subgroups. So here we have a summary of the results that we found. The first 3 columns are the clinical variables, where we use the median and interquantile range. The 3 following columns are the frequency of the mutations in the different subgroups. And in purple, we have highlighted the subgroups that are above average. And in orange, we have the subgroups that are highlighted below average. So you can see that the white blood cell count is the clinical variable that is more variable between the subgroups. Indeed, this was the variable that was used to define the myeloleukopenic subgroup. And regarding the mutations, we see that we have a high variability in the frequency of ASXL1 and of SF2. So next, we wonder if we had differences in prognosis between these subgroups. First, we explored if there were how these patients were classified belonging to the IPCSM risk score classification. As you can see, there are two subgroups, the loss of white and myeloleukopenic, that are enriched in patients identified as very low or low risk. And we also have two subgroups that are identified as monosomy 7 and trisomy 8 that are enriched in patients with high or very high risk. So if we check the survival for these groups, we see the same pattern that we observed for the IPCSM. The two subgroups, the trisomy 8 and monosomy 7, have a lower survival than the other groups, in line with the results from the IPCSM. But at this point, we wonder if the IPCSM score was working equally well in all the subgroups. So we repeated this analysis, but stratifying by IPCSM score. So if the IPCSM score is working correctly, we should expect something like the figure on the left. So all these individuals are classified as having low risk. So the subgroups shouldn't give any additional information. All the overall survival curves should more or less overlap. However, if we go to the moderate low group, we can observe that the TET2B allelic group have a much worse survival than the other subgroups. Next, we run the analysis the other way around. We went to the different subgroups and stratified by IPCSM. Again, we would expect to have something like the figure of the left, where we can see the different curves, and with worse survival by, so the worse the survival, the higher the IPCSM category. However, if we look at the TET2B allelic, again, we see a much higher overlap between the moderate low, moderate high, and high groups. So finally, at this point that we identified that the moderate low are the higher risk if they are TET2B allelic, we wonder how high should be the risk for the other subgroups to mimic the risk that we identified for the moderate low TET2B allelic. So here in the curves, you have in blue always TET2B allelic moderate low patients, and we compare them with the other subgroups, moderate high and high. And as you can see, the risk of the moderate low TET2B allelic patients is comparable to the risk of the high for the other subgroups. So at this point, that we identified that the IPCSM score at least is not correctly predicting the risk for the TET2B allelic subgroup, at least when they are in the moderate low, moderate high. We wonder what can be the reason for these discrepancies. So in the IPCSM score, the assumption is that the risk factors are independent between them. So they should be the same, we should have the same hazard risk for any of the subgroups when compared with the IPCSM cohort. But this is not the case. So here we have the hazard risk for two mutations that are included in the IPCSM score, ASXL1 and SRSF2. And as you can see in the plot on the left, these subgroups, trisomy 8 and monosomy 7, have a much higher hazard risk if they have this mutation than identified in the IPCSM cohort. For the TET2B allelic, this effect is also present, but is not so pronounced. However, if you go to the other mutation, we can see that that TET2B allelic, if they have these mutations in SRSF2, have a much higher risk than the risk identified in the full cohort. If we go to the survival curves, we see exactly the same effect, and you can see that the effect is much stronger. The effects of SRF2 mutations is stronger in TET2B allelic patients than in the whole cohort. So we hypothesize that there might be an interaction between these subgroups and the risk factors that are included in the IPCSM score. To conclude, our low blast subgroups have distinctive clinical, karyotypic, and molecular features, and they can be used to refine the IPCSM risk prediction, as we can see with these TET2B allelic patients. However, the results is done only with the IPCSM cohort, and we are open to collaborate with additional cohorts to replicate these findings and have more statistical power. And thank you very much.
Thank you very much for presenting that wonderful work. And I think there is a question.
Hi, thank you very much. Very nice presentation. So I have a question regarding the TET2 multi-hit biallelic that you identified in your study. Did you have a chance to have a look in the monocyte count, if they resembles like a more MDS MPN, if you have that data in your data set, if it's different from others? Because also it's association with SRSF2, A6L1 might be.
Okay, so during the preprocessing of the data, we use the classification that is included in the cohort that I think that is I don't remember, it's the WHO of the ICC, and we remove those patients that were classified as MDS, MPN. Well, we remove any patient that wasn't classified as MDS, like a pure MDS, let's say.
Okay, so there was no difference in monocytes, even in the pure MDS low blast forms, between the TET2 biallelic and the others?
So there might be differences in monocytes, because monocytes are included, but I don't remember by heart there are differences, especially inside these subgroups. So, because in the summary, I remember there were differences I checked the differences between all the white blood cell types. But I just, for the presentation, I took the summary because I was very correlated with the other ones, but there might be still differences in the monocytes here.
Okay, thank you very much. Thank you.
Can I make a comment on previous question? So in the molecular taxonomy paper we published recently in Blood, there was a close correlation between TET2 multi-hit state and monocytosis, not just in MDS, but across all myeloid neoplasm, including CMML and others.
Okay. In sake of time, I'm sorry, but we are going to continue with the last presentation. Thank you very much. And you can continue the discussion afterwards.
And last but certainly not least, Dr. Marco Raddi on our last abstract from Florence, Italy, the dark side of ring sideroblasts and myelodysplastic neoplasms with low blasts.
Thank you very much for the kind introduction. Good evening to everyone. I'd like to thank the scientific committee for selecting our abstract, in which I will detect the negative aspect of ring sideroblast presence in the bone marrow of MDS with low blast count. So I have nothing to disclose. So as we all very well know, SF3B1 mutation is strongly associated with the presence of bone marrow ring sideroblast, in which iron accumulates in the form of mitochondrial ferritin in erythroid precursors. And however, around 20% of MDSRS cases do not harbor this mutation, and they have an inferior outcome compared to the SF3B1 mutated. So in this study, we just focus on MDS with low blast count, no 5q deletion, and with presence of ring sideroblasts with a positivity threshold defined according to WHO criteria in respect to SF3B1 mutational status. Whenever possible, in case of SF3B1 wild-type forms, we also excluded eventual secondary non-clonal cause of RS formation, like toxic metabolic or certain drugs. And in order to have more abundant cohort, we first interrogated the public IPSSM data sets comparing the wild-type and mutated SF3B1 group within MDSRS to identify distinguishing laboratory morphological features that could correlate with the SF3B1 mutational status. We also performed outcome analysis that confirmed previous submission, and we also made an in-depth genetic characterization of these two groups. Finally, we also analyzed our internal cohorts in these two groups, where we perform an extensive flow cytometry analysis of the bone marrow to also potentially identify distinguished phenotypic features between these two groups. So we first observed that compared to the SF3B1 mutated cases, MDSRS without SF3B1 mutation are younger and more frequently have an etiology of secondary or therapy-related MDS. In terms of blood count, we confirm that SF3B1 wild-type cases have significantly lower neutrophil counts and platelet counts, and this, of course, translates with a significantly higher fraction of thrombocytopenic, neutropenic, or bicytopenic, whereas hemoglobin levels were similar between the two. And bone marrow shows that MDS-RS without SF3B1 mutation have a lower percentage of ring sideroblasts and a significantly higher frequency of multilineage dysplasia. Outcome analysis confirm what we already known, that SF3B1 mutation carries a positive prognostic values that is retained, however, only in the lower risk setting according to IPSSR. We didn't observe any difference in the higher risk setting, and there was no prognostic impact of multilineage versus single lineage dysplasia in both groups. And this, of course, translated into higher prognostic scores, including IPSSM and an increased number of mutations in the wild-type group. Then we digged into the cytogenetic features of these two groups, and we observed that SF3B1 wild-type MDS-RS show higher cases with an adverse karyotype, mostly characterized by chromosome 7 abnormalities and complex karyotype, which were nearly absent in the SF3B1 mutated group. And of note, just a minority of these cases with an adverse cytogenetics had actually a secondary or a therapy-related MDS. Regarding the mutational landscape, these two forms displays a completely different pattern of mutation. SF3B1 positive were enriched in TET2 and DMT3A mutation compared to the wild-type counterpart, whereas SF3B1 wild-type MDS-RS were enriched in T53 mutation. This was already shown, and we confirm here, and also in other non-splicing factor mutation like UTF1, SRSF2, and also S6L1. These together with worse cytopenias, the cytogenetic risk translated into a completely opposite pattern of the redistribution according to IPSSM categories, where SF3B1 wild-type cases were most often fallen most often in the higher risk categories. We were, of course, interested in the T53 within SF3B1 wild-type MDS-RS cases, and we observed that majority of T53 mutated MDS-RS without SF3B1 mutation were indeed T53 multi-hit mutated, which were very rare in the SF3B1 mutated group. And that a quarter of them were also secondary or therapy related. And interestingly, we also observed that the variants were also different. In particular, I've shown here that only MDS-RS without SF3B1 mutation carry frameshift T53 mutation that may indicate that the function is more perturbated and more profoundly altered in the SF3B1 wild-type group. So I think the answer to the question I want to convince you that is yes, we should perform more per staining to detect the presence of ring sideroblasts, because not only in characteristic MDS-RS with isolated anemia and single lineage dysplasia, because they may uncover and may be informative and surrogates of adverse genetic forms of MDS, even in the absence of an excess of blast. So we carried a multivariable analysis that confirmed that these variables were significantly associated with the SF3B1 mutational status. And also, if we remove the karyotype features and we only use clinical and morphological data, we can identify this form, in particular if patients are younger, are thrombocytopenic, and display multilineage dysplasia. So finally, we also analyzed our cohort of patients for additional analysis. And here I'm showing you some phenotypic and flow cytometric data. And we observed that MDSRS without SF3B1 mutation have a significant increase in the monocytic bone marrow population compared to the SF3B1 mutated form, and that the characteristic increase of immature erythroid cells that characterize SF3B1 positive MDSRS is not present in wild-type forms. Also, expression of CD71 on erythroid cells was significantly lower in the SF3B1 wild-type group, and interestingly, reticulocytes were higher in the wild-type group, suggesting that maybe terminal erythroid differentiation is not so important and predominant in the wild-type group. Finally, we also have a look in how these patients' cases respond to standard ISA treatment, anemia treatments. So we focus on the lower risk setting, and we observed, even though not significant, but a trend towards lower inferior response rate in the SF3B1 wild-type group to both ISAs as first line and subsequent treatment with Luspatercept. So my take-home message, again, is that per-staining is important. We should do it more often because it can be used as a surrogate indicative of adverse forms of MDS in case of MDS with low blast. In a specific clinical and morphological context, they may uncover adverse forms of MDS characterized by adverse cytogenetics, biallelic TP53 dysfunction, and of course, an unfavorable clinical course and poorer response to treatment. So with that, I'd like to thank you for your attention, and I'm happy to take your questions.
Please.
Thank you very much for a very nice talk, Marco. So just a question. I think Gabriele Todisco published a paper a couple of years ago with similar data. I wonder whether you looked at the association between the distribution or the enrichment of the erythroid compartment by flow cytometry and outcomes, because that was a part of the paper of Gabriele Todisco about that.
Yeah, I read the paper. So in the Todisco's cohort also included excess of blast cases and AML. So it's quite different, more heterogeneous population. And he identified an enrichment of the megakaryocytic erythroid compartment within the SF3B1 group. The flow cytometric data are only available for our cohort, but we are trying to expand also with collaborations these cases and potentially find also prognostic values of this repartition of different cell types in the bone marrow.
Yeah, because that would be very interesting to see whether you can confirm
I agree.
also in a low blast population.
Yeah,
thank you very much.
Thank you.
Thank you so much. We hope everyone will stick around.
Can I ask a question?
Okay.
This is very nice data following that, but have you looked at different isoforms of the SF3B1, for instance, K700E versus the others? That would be really interesting.
Yes. I mean, in the IPSSM dataset, majority, of course, were the classical ones. We are trying also to correlate if different hotspots have different phenotypic, let's say, morphology or phenotypes. And but we are trying to find more cases and create a more comprehensible story about that. So we are doing that. Thanks.
Thank you. That was very nice.
Thank you.
And I think it's immediately time for the MDS Foundation EHA Joint Symposium. Thank you.